presentation about the use of big data to fight pandemics. And I am Alberto San Giovanni Vincentelli. I'm a professor at the University of California at Berkeley, and I have the honor of monitoring this panel. We have 5 participants to the panel. So we will start first with Marilise Gorgens. She is with the Health Emergency Preparedness and Response Program and the Digital Health Innovation Lead of World Bank. So Marilise's organization has prepared a very interesting report about the use of data and how data will offer opportunities to all of us and to the economy in general. And I strongly encourage you to go to the internet and download the report. There is an overview, it's about 35 pages, and then the long version of it is 150 pages, but every page is worth reading. So without further ado, I would like to ask Marilise to start her position statement. Marilise?
Thank you very much, and good afternoon. Thank you for the opportunity to present and be with you today. I want to just ask, will you project the slide from your side, or do you want me to project the slide from my side?
It's fine if you do it from your side. You should share the screen so that we can all see it.
It says that the host disabled participant screen sharing, so I'm not able to share my screen. If Emmanuel could share from his side, that would be good, or somebody could share from your side. I did share my slides, but I'm not able to share my screen, unfortunately. So when I tried to share my screen, it said that the host disabled screen sharing by participants, which is why I'm not able to share the screen. In the meantime, while we are sorting out this, thank you very much. While we're sorting out this, sorry about that technical glitch. Thank you for the opportunity to share with you today. What I'm going to speak with you about for a few minutes is about thinking about data for COVID and data relating to pandemics within the bigger context of data for better lives in a pandemic and post-pandemic era. How do we balance the incentives and ensure that all the private and public data that are available bring value to all of us, and particularly do not particularly bring value to the poor? So, as Alberto mentioned, the World Bank prepares every year a World Development Report on the next slide. And the 2021 World Development Report, if we can move to the next slide, the 2021 World Development Report is about data, and particularly data for better lives. The report makes 5 key points. First, that we need a new social contract for data that is based on trust, value, and equity. I think in the COVID era, we've seen the importance of value, trust, and equity in terms of information, misinformation, and how that information is used to influence public discourse. We know that we still have a very long way to go on data governance. We know that data governance, particularly cross-border data governance, has important economic implications. If we provide telemedicine services, for example, in Malawi by a service provider in Nigeria or Kenya, the data travels through across border, and how are these trans-border activities regulated? We know that data governance is not something that countries can tackle on their own, that it's a matter for international cooperation, and we would encourage countries to aspire to the vision of achieving an integrated national data system, and so that in future, the data that we need to better use and predict and prevent pandemics or other emergencies caused by other causes, disasters, and so on, that we can use the data that is part of an integrated national data system. Next slide. So if we look at this social contract for data, as I said, we're going to talk a lot today in the presentations today. We'll focus a lot on value. The two aspects that I would like us to suggest are equally important for us to focus on as we have this conversation around using data for pandemics is to equally think about trust, the public's trust in that data, and how the public entrusts governments and the private sector with their data, as well as the issue of equity, particularly for developing and low income countries, and the poor in any country typically have less access to data and data services. And how do we ensure that the social contract that we build around using data to improve things has equity built in at its foundations? Next slide. Again, I think since this conversation is particularly about data for pandemics, we've seen all the conversations around whether it is from contact tracing to vaccine certificates. We need both enablers for data use, but also safeguards for data use in a time of COVID and also for future pandemics. Which brings me to the last point that I want to raise as part of my opening statement on the next slide, and that is the importance of data governance. If we are going to create this new social contract for data that is based not just on the value we can get from data, but on trust and on equity, we need a good data governance framework. So next slide, please. On the next slide, you can see that when we think about data governance, and this is discussed in detail in the World Development Report, which you're welcome to read, to download and read, there are both national and international, if we look at the two rows, components to data governance, and there are also different dimensions to data governance. We have to think in terms about data governance in terms of infrastructure policies at the national and international level. We have to think about it in terms of laws and regulations, and thinking about both safeguards and enablers, cybersecurity conventions, interoperability standards, some of which are national and some of which are international. And all of these are incredibly important, and we've seen them play out in the lack of them being available in many countries as being critical areas that have hampered and prevented the maximum use of data during the COVID pandemic. We have an opportunity to improve this for future pandemics, health emergencies, and other disasters. You can also see that in terms of economic policies and institutions responsible for data governance. These are all the dimensions at country level and at international level we need to think about when we think about how do we govern this new social contract of managing data for better lives. Next slide. On the next slide, I show you for the countries in the world where we have done a representative survey, high income, low income, upper middle income, lower middle income, and in sub-Saharan Africa. If we look at the data regulation and the different data governance dimensions in terms of regulations, you can see where countries are doing well, where the lines are towards the outer ends of the diagram, and where the lines are towards the more towards the center is where there are weaknesses. So you can see that in terms of cross-border data transactions and flows, in terms of non-personal data protection, so the data generated through routine health system, for example, and the use of private intent data. Those are the particular areas where regulations and governance are particularly poor, and we have to focus on them in an increasing way. And then lastly, just to show you, again, this is from another analysis on the next slide, please. Another analysis that we had done based on data that we'd collected. This is from the Africa region, and it shows you that in these particular countries in the Africa region, what are the country's scores in terms of creating enablers and safeguards for data to be protected, but also data to be used. And I would call these the two flip sides of the coin when we want to have a conversation about using data for pandemics. We need both the mechanisms and incentives to enable it to happen. So we need to create the right enabling environment, but we also need to create safeguards. And the key point that this slide makes is that in many countries, there's a balance. Some countries focus a lot more on safeguards, the red line, than on enablers in terms of regulations for data use, where you, as you can see, more towards the bottom, countries focus more on enablers than on safeguards. And so the real challenge, I think, before us globally, as we think about how we have used data during the current pandemic, but also how we can improve the global and national systems moving forward, is how we find this balance within the bigger context of data, of the social contract that exists in terms of value, equity, and trust, to use data to better lives, to use data to prevent and mitigate and respond to future pandemics for everybody, not just high income countries, but everybody from low income to high income countries. Thank you very much.
Thank you very much for your very clear presentation. Now, since Marie-Lise pointed out the different rules and regulations in different countries on the use of data, and how some countries are better than others, both in terms of governance, generic governance, and data governance. So we have now the ambassador of New Zealand, Anthony Simpson, and certainly New Zealand has been a model country for dealing with COVID, and in general is a country that really pays attention to the governance of data and the economy. So I would just ask Anthony Simpson to talk to us about his country position, and also about what kind of safeguards we have to put about the use of bad data, because data is not just data, it's good data and bad data. So Anthony, and thank you very much, Marie-Lise.
So, Buonasera, thank you very much for inviting me to join you this afternoon. Can I first of all say what a privilege it is to be included in such a distinguished panel, and as by far the least expert member of this panel, my comments will reflect the observations of my country and of myself from my experiences both in my own country of New Zealand, but also of observing events here in Italy, where I've spent most of the pandemic. I should note that my comments relate both to the application of big data, but also to data more generally during the course of the pandemic. So data is back, baby. Amongst many other things, 2020 may be remembered as the year in which many people came to understand just how much the quality of their lives depends on the analysis and the use of data. Most of you will recall that in the years leading up to the COVID-19 pandemic, there was growing concern about the emergence of alternative facts and a post-truth society. Commentators decried what they saw as a growing disdain for facts, for data, and for sober analysis in favor of emotive opinion, and an increasing rejection of traditional sources of information in favor of questionable online media. These trends, it seemed, were driven in large part by the remorseless logic of social media algorithms. Trapped in an endless hall of mirrors that was reflecting their own preferences and prejudices back to them, people were increasingly adrift in a sea of subjectivity and suspicious of any information or any source that dared to contradict them. These trends were in turn reflected in deepening social and political cleavages, and in an increasingly angry and emotive public discourse. Sometimes these trends could take on almost comic characteristics. For the first time in many centuries, the number of people believing that the earth was flat appeared to be increasing. Numerous other claims were able to earn a remarkable number of online believers despite their absurdity. One notable example claimed that the country of Australia did not in fact exist, a claim that, as one of its closest neighbours, I can confirm for you is unfortunately merely wishful thinking. Whatever the true nature and causes of these phenomena, the COVID-19 pandemic at first appeared to be the perfect antidote to the post-truth society. That is because, to mangle a famous aphorism, data simply doesn't care about your feelings. And during a global pandemic, the scope, accuracy, and effective use of epidemiological data has profound consequences. Data is used to map the characteristics of a virus, to gauge how easily it spreads, how it behaves in different conditions, and its severity in different categories of patients. Data is used to monitor and map the spread of a virus and to predict its further progression under different scenarios. Critically, data is used to predict when the limits of a country's health systems will be reached, and to do so far enough in advance to influence that outcome. Data is also critical for developing, testing, and applying different treatments and vaccines in a safe and effective manner. And various database tools were trialed to support vital tasks, such as contact tracing and vaccine certification. It's fair to say that for a time, many of us became almost obsessed with data. Both here in Italy and in my own country, New Zealand, during the first phase of the pandemic, the daily COVID briefings were compulsory viewing for most of the nation. People were glued to their television sets, waiting for an update on the numbers, how many new cases, how many hospitalized, how many dead, and what it might mean for the government's response. In subsequent phases of the pandemic, the same data has come to have a fundamental impact on all aspects of our lives. RT ratios, ICU occupation rates, and vaccination numbers have determined whether we can go to work or school, whether shops and restaurants can open, whether we need to wear masks, and whether we are allowed to cross borders. The past 18 months have also been difficult ones for a number of prominent so-called post-truth politicians. Those who have actively spurned expertise and whose appeal has relied primarily on emotive signaling were in some cases badly exposed. And at the same time, a desperate hunger for accurate information and for informed guidance has produced some unlikely heroes and heartthrobs from amongst the ranks of the quietly competent. Dr. Ashley Bloomfield, New Zealand's softly spoken, bespectacled Director of Public Health, achieved something approaching cult status in my country for his calm, clear daily briefings, to the extent that for a time, the genre of Ashley Bloomfield tribute videos were a major trend on YouTube. If you don't believe me, you can just look it up, but just be warned, not all of them are entirely suitable for work. So has the past 18 months presented an unmitigated triumph of data that has closed the book on alternative facts forever? Well, obviously the answer to this question is no. So I'd like to offer in my opening comments some basic reflections on what I believe we've learned over the past 18 months about the importance and power of data during a pandemic, but also about some of its limitations. First, we have learned that access to extensive and accurate systems for collecting and analysing epidemiological and other data provides an extremely powerful public health tool. Those countries that possess such frameworks have had an enormous advantage in their efforts to manage the pandemic, while those that do not have found themselves with far fewer options. And this really speaks to some of the equity issues between countries and between regions that were referred to by the previous speaker. But good data only informs good decisions. It doesn't guarantee them. And so the second lesson we have learned is that governments that consciously and consistently base their responses on robust epidemiological data generally fare much better than those who don't. At the same time, no government at the start of this pandemic had the information, the understanding, and the tools that it needed to effectively gather the required data or to make sense of this data once it was gathered. So the third lesson is that global information sharing of data is crucial for enabling the effective use of this data. That has proved true time and again in this pandemic, whether it be the sharing of genome sequencing, data on the transmissibility of different variants or their lethality in different populations, the results of research into potential treatments, or the analysis of the effectiveness and the side effects of different vaccines. The scale of such cooperation during the current pandemic has been truly unprecedented, and perhaps represents one of the greatest success stories of the current crisis. Unfortunately, the past 18 months have confirmed that robust data sets can appear almost irrelevant if not matched with clear, consistent, and convincing public communications. We have seen that even relatively minor communications missteps or inconsistencies have had profound and long-lasting impacts on public confidence and compliance. Moreover, many of us have proven ourselves extremely poor at interpreting data, particularly when it comes to evaluating levels of personal risk. And we have seen that communities who are already skeptical of government authority and messaging can be remarkably impervious to even the most compelling data. Those governments perceived as having performed well during this pandemic are above all those who have risen to this communications challenge and have managed to retain the confidence of their citizens during even the most difficult phases of the crisis. However, even these governments have struggled to combat the relentless tide of misinformation and conspiracy theories circulating on social media, which have worked to dangerously undermine public health messaging on everything from the safety of vaccines, the efficacy of masks, and the use of untested treatments, to the very existence of the virus itself. Finally, the pandemic is teaching us a great deal about the effectiveness of individual data tools in pandemic management. There were high hopes at the start of the pandemic that data-based mobile apps could play a crucial role in national tracking and tracing systems. For the most part, the impact of these apps has proved disappointing due to insufficient public buy-in and ongoing data privacy concerns. And this again speaks to the issue raised by the previous speaker about the importance of not only having effective privacy and information security systems, but ensuring that there is broad and widespread confidence in those systems. So far, the use of digital vaccine certificates and green passes has proved more effective as a tool for safely managing the removal of social and economic restrictions, although not without still meeting fierce opposition from some quarters. So to conclude, with the pandemic yet to run its course, we still have much to learn about the role of data in efforts to contain and combat it. The crisis has certainly demonstrated the fundamental importance of data to pandemic management, but it has also clearly demonstrated that the data itself is not enough, and that a firm commitment to data-based policies and clear, effective communications are required to derive its full benefits. Time will tell how the story of data, and of course of big data specifically, will be written during the next phase of this pandemic.
Thank you very much, Anthony. It was a very comprehensive presentation about some of the most important issues on the use of data. And next presentation is going to be by Emanuele Di Angelo Antonio, who is the head for a Center of Health Data Science in the Human Technopole. For people who do not know, Human Technopole is the largest endeavor in Italy about biological research, and this particular area, the use of health data science, is in collaboration with Politecnico di Milano, and it is a very important topic that we need to study in great detail. Also, the speaker after Emanuele, Vincenzo, is going to talk about the importance of data in general for health. And but we do need to develop technologies to be sure that we can extract the information without violating privacy, but without being completely sidetracked by the need of preserving privacy. So there are techniques, as Giuseppe will tell at the end of the presentation, in which you can obfuscate the data sufficiently enough that you can extract what you need to do your inferences, and at the same time not revealing the identity of people who gave the data. So without further ado, let's move to Emanuele. Emanuele, please.
Hi, good afternoon, and well, thanks for inviting me for this session. I think it's very exciting, and it's really a great line of speakers. So what I really want to discuss over the next few minutes really about some of the use of data during the pandemic, especially in relation to some example that here from England. So I'm, in addition to be the head of the Health Data Science Center at the Human Technopole, as well as I'm a professor of clinical epidemiology here at the University of Cambridge, where I'm currently based. So I'm really sorry to not be able to travel to Rome, where actually is my hometown. But you know, there's the pandemic. You know, even here in my household, I have a daughter that is positive for COVID, so I'm not able to move around. So it's one of the consequences I think all of us are suffering. So if you go to the next slide, so I think what I really want to focus this brief presentation is about the big data and use of big data in health science. And when I'm referring to health data in health science, is really about all the data that surrounded clinical information, from visit to the doctors to hospital visit to all the data coming through the health system in different countries. And if you go to the next slide, so the data during the COVID-19 pandemic has been used in many aspects. It's been using from track and tracing individuals, to respond to different issues related to the pandemic. And really, I want to focus and provide a couple of examples. It's really about the clinical management in some way, and really focusing on two examples. One in relation to use of vaccine, and then the other one is really about in relation to vaccine trackers. So if you go to the next one, please, and sorry, the next one. And then, so in relation to COVID-19 pandemic and use of data, now this is the example here I'm bringing here is about the CVD COVID UK consortium. And it's really in some way it's very difficult to speak after the ambassador of New Zealand, a country where the science and the politics have been really worked together to respond to the pandemic, and really bringing an example from UK where sometimes the politics and the science haven't really worked together over the last 18 months. But I think in terms of the science, really UK has been really providing some key example of how data can be used. And here, really I'm bringing this example as the way in which using data from the health system, and so bringing together data from the primary care practice to the hospital, to the different registry, as well to the COVID-19 testing data, has been able to use and to respond to some of the big questions around safety and efficiency of vaccine. And so the way of being really able to do this is really through bringing this data together in what is called a trust research environment, in which basically data can be used by research, but at the same way it can be protected. And this is really referring as well to the first presentation, really can be used in appropriate and safe way. And so using this data, basically what we've been able to do here in UK is building together a data set that will basically bring together data for about 55 million individuals that actually were alive on January 2020, and that's been really covering basically 96% of the population. And really, these allow, if you go to the next slide, these have been some very interesting analysis about the efficiency of vaccine, especially to respond to some of the concern about the potential side effect. So in this slide, I'm really reporting really a snapshot of some of the data that are now under review to one of the medical journal, one scientific journal. It's really looking at how the effect of both the Pfizer and the AstraZeneca vaccine has been helpful not only to reduce the contact with the virus, so the really sort of the infection, but as well to reduce other events. And so this is really in some way opposite to some of the claim that actually some of these events are actually increased by this vaccine. You can see if this is a report of the risk on the x-axis, and then the pre and post vaccination on the y-axis. You can see actually that the risk is usually lower for people taking the vaccine compared to people not taking the vaccine. This is highlighted by the blue and the red line, both for the venous events, so all the events are related to the venous compartment of the body, but as well to the arterial events. So those are, for example, like heart attack or stroke, are actually lower in this endeavor. So, but at the same time, use of this data, so if you go to the next slide, I actually highlighted how on one side we have a decrease in risk for many of the events. On the other side, there's some specific potential limited increase in risk for other events. And here's the example of the only two that among the more than 300 diseases are increased by using, in this case, the AstraZeneca vaccine, in which there is a small increase in risk for intracranial venous thrombosis, so a very specific disease, and then as well thrombocytopenia. So, and I think what I want to highlight is that this use of data, this large amount of data, really allowed to disentangle, the different effect in this case, side effect of vaccine, but as well to highlight how this small risk is really outweighed by the benefit of using vaccine, both in relation to the infection, but as well in relation to preventing other disease. And so really sort of, counterbalance some of the claims that have been made in the past that, the risk of this vaccine unsafe. And we actually know that many of the majority of the treatment that we're actually using, and actually even long-term flying from long-term basically findings really actually carrying a higher risk than this actual use of this vaccine. And so really highlighting how use of this data, especially for these rare events, is really helpful to pinpoint what is the potential risk and actually put that in the context of the wider issue in relation to health and the pandemics. And so the last slide, if you go to the last slide I want to show, is really about if you guys move to the last slide, it's a different example from UK. This is in relation to a genetic effort that's been built up in UK. That's called the COG UK, the COVID-19 Genomic UK Consortium. In that, what these data were just published yesterday evening on Nature, and really actually showing that the UK has been able to set up possibly the largest genome sequencing in the world, and up to yesterday, I think more than 1 million genome of virus have been sequenced, and actually showing how this effort has been able to track how the different epidemic is going, how the different variant has been, for example, spread across UK. You can see from the map on the right, and actually how there's been different sub-epidemic within the larger pandemic. So you can see that there's initial of the alpha variant spreading. You can see that on the right chart with the blue, the purple, and somewhat the green, and then how does it move to alpha in the red sort of area, and then how to move to the brown one, so the delta one. Now how actually now the delta is the variant, the variant that is actually, the majority of the cases are actually delta variant in UK. So 98% of those are related to delta variant. So really able to track the different aspect of the pandemic and the evolution of the pandemic is really providing some useful information, almost live information in this case, and this using this genomic effort. So if you can go to the next slide. So just to conclude this brief intervention, really, I think that the major clinical insight can be really achieved through enabling use of data. This is in general to this pandemic, but we'll decide that it's not limited to this pandemic. I think use of data and good use of data is really important to fight not only this pandemic, but as well many other health-related issues that we're facing up to now. And that actually, there need to be a great collaboration from different disciplines, really to generate and advance this use of data and really to interpret those information. And then that there really need to be a creation of informatic infrastructure that allow this capability, that will allow this use of data science. We need to develop new methods. We need to develop new systems that allow this rapid harvest of this amount of data. And I think UK has been a good example, I would say, on use of some of those data. It has not been a good example in how the data are being used by some of the politicians. And this is actually another point that actually, as the previous speaker raised, there really need to be then hand-in-hand sort of discussion between scientists and politicians how this data can be used and can put up the best use of them. And thanks for your attention.
Thank you very much, Eugenio. Now we go to another important institution in Italy, and it's going to be Vincenzo Valentini, who is going to talk about his experience. Vincenzo is the head of an important research organization, which is called the Gemelli Generator. So we heard about incubators, we heard about accelerators, we have also the generators that are actually generating ideas that then can be transferred into incubation and then finally to the market. But this is a joint venture, if you like, between the hospital, the Gemelli Hospital, which is a very large hospital in Rome, and university, the Catholic University in Rome. And even though the Gemelli is indeed a branch of the university, it doesn't mean that they are the same thing. And actually, a collaboration is not for granted, especially when it comes to computer science and other parallel sciences to medicine. So Vincenzo, illuminate us.
Thank you very much. Good afternoon to everybody. Yes, I would like to share an experience, how a lab on AI big data react to the COVID challenges. And the Gemelli Hospital was mentioned is an academic hospital and a research institute with 1,500 beds, very well established here in Rome as a rule for the health issues that we have in the city. One value that in Gemelli we have to consider that to appreciate a lot is that along the last 30 years, even we change a lot of IT platforms, the addresses of each data were not lost. So at the end of the story, we have in our repository, in our data warehouse, more than 760 million of granular data. And granular data is not only hemoglobin, it's also a report of radiologists, of pathologists. And now, you know, with the natural languages processing, understanding, each of these reports can be considered can foster 40, 50 data. So it's quite large, more than 3,500,000 patients that were inside. So in our lab, the architecture of the lab is that we extend the protection system of our data warehouse, putting inside the wall of our data warehouse security system 2 layers. One layer is with the crawler mini bot. We were trained to go to look for the data, to mine the data, but to transfer the data in the second layer of data mart by coding this data accordingly in ontology that our team that is mix of data scientists and clinician devoted, so people with these 2 lobes in the brain, one is doctor, one is IT, that can be connected very well, and again between them, create ontology, but namely created a semantic rule for doing a first level of quality assessment, just to provide that by the cross-checking, we will put in the data mart at least a very high level of quality of data on daily basis. And that is transparent based on what we are the recommendation of explainable AI management. And then there is a second layer of bots that provide 3 major benefits, we can say, in the system. One is the data clustering, so it means produce aggregation of data that could be of value in the different decision moments of the life of a research institute and of a large hospital. So even we'll follow, we have a data mart for a tumors, specific tumor is different. What is important for the doctors, for the nurses to know when they are in the clinic, or when they are in the hospital, or when they are in the ER, or when they are in other places. So that is the clustering the data accordingly, the need of the specific ecosystem where we have to use this data, or to create a prediction model. Doctors and also administrators needs to have some supporting tools for taking their own decision, and finally for clinical trial support research. So look at the 2 experiences that I want to share you. One is to serve the decision maker of the hospital. One is to serve doctor at the bedside. For the first, it was to create this what we call the crawler bots. So we went through the different data silos of data that we have in our data warehouse. We interact with this data with the system to pick up the data with the natural language processing systems, coding the data, looking at the cross-referencing semantic just to provide a good quality of data to populate this second layer of data mart that was made for the COVID. Just to say, to take saturation is written by nurses or by doctors in 36 different ways in the electronic charts, and the system can detect everything. So now every saturation is online in our system. So we took the benefit to the benefit. So we were one of the COVID hospital of the regions, and we collected 3,000 patients with post-COVID infection in the hospital, and this is the analysis of last September. And with this background, we could provide to decision maker an online view of what is going on in the picture, looking at the trends, looking at what are in the ER, looking what are in the recovery system, just a picture that it will be really consistent with the different challenges that we have, because Gemelli are right to have more than 600 COVID positive patients in the world, and now is going to have to have a separate hospital with 120 beds only. So we had to move to squeeze and enlarge. That was a system of a dashboard for the decision maker that was online and automatically updated by the systems. And they provide really a great benefit in the ontology and the feedback that we got, what is would be important to show in the different contexts of the decision makers. And that is the second experience that we tested, put in place, and now we are in a deployment perspective validation. That is to look if we can have some early risk score of what would be the risk for the patient to go into emergency and also to die. And that is looking at the different, as I mentioned, domain of data that became along the stay of the patient in the hospital, from the emergency to the first ward or to the intensity care, that we have a more accumulation data, and the risk analysis could be tailored according to the extension data that we have along the different moments. Of course, we had accuracy, because no risk models is perfect, but we can declare what is the reliability that we tested retrospectively and prospectively, and before putting it in the bedside. And you see that we have quite good performance for the negative prediction of high risk, and fair performance with 84% to predict worsening of the condition of the patient. And then that is the dashboard with the risk score and all the other data that are helpful for the infectivologist, for the intensive doctor, that to have in one shot, in one screen, even they were in many different silos of our experience. So that is the experience. Is a very small experience, but they offer us that if you have a machine, if you have people that can be connected each other to find what is the dialogue between data scientist and doctor in an environment that could put him really on the road to benefit, something of good can happen. Thank you for your attention.
Thank you very much, Vincenzo. This was a very interesting experiment. I myself am doing something similar with University of California, San Francisco, with a clinical university, part of the University of California system. We are Berkeley. We have everything but medicine, and University of California, San Francisco has only medicine. So in some sense, it's our Policlinico Gemelli, in some sense.
Yes, but you have also very nice bridges between,
Yes.
Across the bay that
Right,
connect both.
Indeed, indeed. And, this one of the things that Vincenzo said is very worth underlining is the interdisciplinarity of the research is essential. So you have to put together the data scientists and the medical doctors, and to find people who can indeed exchange experience and work speaking a different language is extremely difficult. And in the United States, what we find is that more and more doctors are taking a degree in computer science. And so that commonality is so much easier than what I found, for example, in Europe. So if anyone here is a student who is interested in these things, and you are interested in the use of big data in health, you should consider taking a dual degree, because that only then we can really make a dent into the problems that we have to face. And last but not least of today's panel is Giuseppe Arbia, who is a professor of statistics in the Department of Economics. So it's completely different than what we have talked about today, but it's very important that someone whose main topic is about statistical data inform us of what we should be careful about, especially when we collect data, because we always say, we said it together before, garbage in, garbage out. So if you put bad data, you cannot expect to get good predictions or good decision making. So decision making can only be done well analyzing good data, not bad data or biased data. Giuseppe.
Yes, thank you, Mr. Chairman, and thank you, the organizer, for inviting me today to this very interesting panel conversation. Do we have to wait for the other people to? I think we lost the connection.
Oh, ouch.
Yeah. We have the other three guests that are isolated.
So we'll wait. So just while we wait, Giuseppe, do you actually work with people in medicine, or not?
Not as much as we should, I think. Well, you mentioned that I am in the Faculty of Economics, but really we are in an interdisciplinary program because it's health economics where we are working in. It's a joint educational project between medicine and economics.
So not only data science, but also
exactly.
economics.
Yes, and then since we are waiting for the connection anyway, you were mentioning before that more and more medical doctors take a degree in computer science. So perhaps they should also consider taking a degree in statistics, or alternatively, because it's really, as you said, it's really multidisciplinary, and the competencies that are linked with the informatic aspect and the building of an informatic system for dealing with data is separate from the skills that are for analyzing the data themselves.
Well, in our program, computer science, we do at least, I'm talking about my department in my university, so very small microcosm, but statistics is a very important thing for computer scientists.
Mm-hmm.
So we ask people in our department to take for their doctorate courses in statistics. So because that's the reason why I was so excited to see you in the panel, because I mean, without knowing statistics, it's just these big data programs mean nothing to me.
Yeah.
It's just hiking all over the place.
Come? Ci stanno loro? Ok.
So well, if that is the case, let's start with your.
Okay. Well, I will show you some just a couple of slides later, but I don't need them. So if people online are connected anyway, you confirm that our three. Okay. Okay, that's good. Right. As a statistician, I feel the duty to draw the attention of the audience and of the panelists here on the quality of the data, as you mentioned in your nice introduction. If we want to approach data analysis in a scientific way, then perhaps we should remember what Jules-Henri Poincaré said about in his Science and Method. He said, a scientist has to look, it's only to look, and look carefully. But he also says, it is better not to look than to look badly. So it's important which data we are looking at. And statistics in the last century, we could say, has learned that in order to generalize the result from our data collection, data should be collected with a planned experiment. Okay, this is the teaching of the father of statisticians, Sir Ronald Fisher. He wrote this important book, The Design of Experiments, where we learn that if we want to generalize the results from a limited number of observations, we should first of all, plan the experiment in advance. But nowadays, we run the risk of forgetting this. We have the illusion that big data will solve all problems. Nowadays, we can sit at the computer, just type few lines of command, and we can scrape data from the web, and in few seconds, we have 1 million data. And we have some open data, for instance. And many health data are, in fact, at least formally open. So you can collect them, and you can start using them. And another example is crowdsourcing. Crowdsourcing is an enormous tool that we have in hand to collect a lot of data, but not necessarily good data. And also, another thing is Internet of Things. We have everywhere devices that collect automatically data, but without a plan of the experiment. And we have the history, which is full of bad example, of bad usage of data. And just to make an example, I think it's a good one to understand what I'm talking about. 1948, in the United States, the presidential election, okay? And there was a statistician at the time, Gallup, that he was very popular because in the last election, he guessed correctly the name of the winner. And he wanted to exploit the technology. And he said, we're going to do something easier to collect quickly the data. And what he did was to use telephone. Okay? At the time, 1948, that was the top technology. And it was very quick. Instead of going house to house, knocking and asking, who are you going to vote for? Just people could be reached by the telephone. And that was a mistake. He got the wrong prediction because he made a sample of people with the telephone. And people with the telephone, no wonder, were the richer, the wealthier people. And wealthier people were more prone to vote for the Republican. So he came out with the announcement that Dewey was the new president. And in the end, the new president wasn't Dewey, it was Truman, the Democrats. Okay? So this is exactly what we do very frequently nowadays. And this is the reason why I want to show you a couple of slides. This is the number of new cases in Italy of COVID-19 since from the beginning. And if we look at this picture, you may say the second wave is the worst. It's so much worse than the first wave. But if we look at another picture, it's completely different. If we look at the number of people that died, then we say the first one was more severe. And we believe more to this second picture than to the first one. Now, what happened in the first wave was that the data were collected without an experiment. They were just collected by convenience. And was the data from medical swabs that were administered to people that had only symptoms. So in the first wave, we were strongly underestimating the asymptomatics and the paucosymptomatic. As a community of statisticians, we were warning all the time about this kind of mistake because underestimating the number of infected people had two major consequences. The first one was we were underestimating the severity of the diffusion. And secondly, we were overestimating the lethality of the virus because we had a number of dead people divided by a number of infected people that were underestimated. So that was bad. And so we should keep in mind that in order for the data to produce useful information, we need to plan the experiment correctly. And so there is an important emphasis that we should put on the data collection. Before building up, I would say, before building up complicated analytical models to analyze them. So the steps are quite clear. We move from data to information. And that's the first step. And the second step, if we get more information, we can enlarge our knowledge. And that's another step. And finally, if we have a higher knowledge about the subject, we can take a better decision because they are empirically grounded. But the first step is the one that, in some sense, is the pillar on which everything else is based on. Do I have a couple of minutes yet? Because when I'm speaking about this, I always have in mind a novel by Jorge Borges. Jorge Luis Borges, which is entitled Babel Library. I think this describes perfectly the situation where we are nowadays. And this library is conceived by the writer as the library that contains all books. The book is a combinatorial problem. What is a book? A book is a combination of the 21 characters, and as they are distributed in a book of, he says, 400 pages and a certain number of characters for each row and a certain number of columns. And like he said, there are 25 to 1 million such books, a number which is not infinite, but is incredibly large. So this is the idea that we have of big data. Everything is there. In that library, there is everything. There is the solution of any problem. But if we don't have a key to collect the right book, we will never reach any good conclusion. And if you think about that, most of those books are meaningless. And this is what big data are. Most of them are meaningless if you are not able to treat them. Few of them have a meaning, but many of them are also deceptive. They say something, but they don't say the truth. And this is another important part of big data. And only a tiny, small part of that library contains true books that answer to our question. This is the right attitude we should have towards big data. We should look at them, trying to look at those that are meaningful and that can be treated for modeling purposes. Okay, thank you.
Thank you very much. This is, I mean, I cannot be in more agreement, but you know, I am an engineer, so an engineer and statistician are close in some sense. Anyways, now the second round, we are going to have a brief kind of statements, and I would pose a question, though, taking the lead from the analysis that Giuseppe had. He said, well, we have to plan the experiment. What does that mean? That we have to think about what is important to obtain and how you go and get the data. Now, there is a tension here between what we need to do a good work in terms of mathematical analysis, statistical analysis, in terms of decision making, and the other side is the protection of the data, which is privacy. Now, I believe that in some cases, privacy has taken the lion's share when it shouldn't, because we have to start thinking about what is to be protected and what can be made public for the good of society. Because if you look at privacy, very often people think of privacy as me, not us, me. And so the point is there something that you can do to allow people to access the data, not necessarily having a label that says Giuseppe Via data, Alberto San Giovanni data? No, it's just to know what is true and what is we can base our decision on. So my question to the panelists will be along this line. So in particular, Marie-Lise, and I hope that the panelists from outside will be able to respond, because I'm getting emails from there. And they say that we should restart the Zoom meeting because they cannot participate. So now, this being the case, then I will ask the people here to begin the discussion. I will start, of course, with Vincenzo, so otherwise, Giuseppe is on the spot all the time.
You pose very well the question, because there is an let me say, philosophical or ontological layer, and then there is a pragmatic layer in terms of what is security. Because for the first layer, always I like some reading that I made a few months ago about the philosophy of the body. And the expression is in Latin, ego sum, ego cum. I am one because I am with the other. So that is a very nice summary of what already 2,000 years ago, Terenzio here in Rome said, sum, homo sum, nothing that is human doesn't belong me. So in the span of 2,000 years, the issue is always based on the relationship, because that I am here is because you acknowledge me that I am here. Because otherwise I can be everywhere. That is something that is philosophical. But that means that from this ontological approach, then the rights has to be always considered ecosystems that are related to many different cultural, economical, historical aspects. So it's a layer that is very dynamic. Unfortunately, we don't learn by the human history. We repeat many times the same errors and the same mistakes. And so we are in the moments where, so that's it. And then I don't want to go further because we will go in analysis. But I'm sure that what is being called individualistic approach is very immature to consider the whole picture. And that is something that we have to be back. I had a very nice discussion 4 weeks ago with the CEO of the major insurance company in Germany. And he stated, and Germany was a lot behind as a government to the European GDPR rules. And he stated that the first case of death in Germany in 2030 will be in 2030 missing interoperable exchanging data. Not exchanging data will be the first cause of death. So that is a statement, but that is going into the pipeline. Security is something that is related to what we like to call algorithmic, the ethic of algorithm. Because, of course, if I open my repository of the hospital to the insurance that want to know how sick are you, just to make a tailored precision medicine, how much I have to ask you to pay me, that is something that is difficult to accept. So, and the balance is something that has to be considered to a real evaluation of what is the ethic and of the use of some algorithmic inside the different ecosystem. So that is my... Giuseppe, your turn.
Yes, it's an incredible important issue, the one that you raised, of course. And in fact, when we speak of the availability, we say availability of data, and we speak of open data. When I said before, you can sit at your desktop and download the data from the web. Well, this is only partially true, because most of the time, when researchers need data to validate their theory, they encounter the wall of confidentiality. So maybe you can access some data because there is not enough protection, but then you're not allowed to publish the results anyway. So this topic here needs to be faced and to find solution to. And well, there are statistical methods to mask individuals and safeguard confidentiality while giving the data availability anyway. So there are techniques that are called masking, and specifically, often we use these techniques to do something which is called the geomasking, because if you move the position of the individual, then it's more difficult to realize what is the name and what is the person that you are observing. But certainly this is an important topic that needs to be solved. And I think that those institutions that are in charge for data diffusion, and they pose limits in terms of the usage, they should take into account the possibility of masking the data before releasing them, before making their disclosed. Okay.
Yeah, so for example, again, in my work with UCSF, we had a similar problem meaning that the data were confidential, so I had to sign I don't know how many papers to get to the data.
Yes.
And then we were, but the good news is that we were able to publish. So, but of course, we did the masking on the association of names to data.
Yes.
But even before accessing the data, so because we had to go actually to the hospital and not leave the hospital, we could only access the data locally at the hospital, not to make this data available widely, because if you access from the university, then you may be able, during the transfer of the data, someone may siphon off the information that you want to keep preferential, right?
Yeah.
But there is another important point, is that it depends what you ask of the data also. Because, for example, you said, I can mask the localization. Yeah, that's fine. But on the other hand, if your interest is to find out how many people in San Francisco are sick of COVID, I cannot do that, right? I can do it kind of locally, right? I can mix a hospital, but yet I cannot do it in such a way that I cannot trace back, right? Of where the person is. But the name, certainly, we can eliminate. Now, in addition, it's very important that the data be available to all the medical professions. So, when you have a new disease, right, COVID, for example, COVID was not known to be a new disease. So people didn't know what to do when they figured out that it was a new disease, and they didn't have enough data. For example, it started in China. China had data. United States did not. So when the pandemics transferred to United States, we were in a condition that we needed the data from China, and thank God we could access, to a certain extent, the data from China. But other important point about the use of data is that in China, the way in which they were looking at chest of patients were with scan, while in the United States were X-rays. And so you needed to transfer the format of what you knew about the disease from scan to X-rays, which is not trivial. And then you had to disseminate the X-rays to the hospital in the United States. So it looks like easy to say, well, I get the data, I analyze the data, I solve the problem. And it's not so. It's a lot of work that goes behind the scene. And you need to be prepared to do that, as you said. I mean, Vincenzo, you wanted to say something.
No, yes. I'm more and more convinced in my professional data mining, and then now in the new lab we have, that one solution for everything is not doable. It doesn't exist. You need to identify what is your challenge, your needs that you want, and then to look what is the data preserving identity systems that you have to employ. For example, I am basically a radiation oncologist, chair of the radiology department. When we share data, we need to mask the face, because you can mask the name of the patient. But if you provide CT scan, of course you can identify immediately who is this guy. So that means that you need to tailor the masking system to the different issue. And the second point, that is something that we have some good experience in terms of proof of concept and practicalities, is the federated learning. So to have a possibility not to move the data from each hospital, but only to connect each hospital where the statistical analysis can be managed, moving from back and forward from the different, doing something locally, provide intermediate outcome, and then go back. And now we have trials in Europe where, based on this federated concept, there were even very protective states like Germany or India. India is also a very protective country. They allow us to do a consortium of shared data, because we show them that is no data left will leave their own hospital, because the analysis will only be, we will go through the hospital, will be managed. So that's our tailored solution for a very well defined question. That is something. But now we have many solutions. What is also important is what you said before, is the willingness to be collaborative and to look for new solutions and new applications. That is a different matter.
Yeah, totally. I see that now the other panelists are back, are they? Okay, so Marlies, can you hear us?
Yes, I can hear.
Okay, Marlies, were you able to hear our conversation up to now, or you were completely disconnected?
No, we were unfortunately completely disconnected.
Okay, so
all three of us.
for you, Tony and Emanuele, I'll do a summary. So what we were discussing was the issue on how to get data in a world where privacy is a major concern, and what are the techniques that we can use to preserve privacy, but at the same time get to the data that we need to access. And so, Marilis, you are in the World Bank, so you see what many countries do. Do you think that we can arrive at a policy that will make sure that when the interest of society is at stake, the privacy of the individual may be tuned in such a way that the data that are necessary to fight some societal disease can be done. So, Marlies.
Thank you very much for the question, and I'm sorry we missed part of the discussion. I'm sure it was very, very interesting. To respond to the question, I think that, to me, the answer lies in balance, and the answer lies in good governance. As I said in my introductory remarks, there is a need between all the stakeholders, government, private individuals, the private sector, industry, for non-governmental organizations, for a new social contract on data to be formed that encapsulates and incorporates what you've just described in terms of sometimes data, there is a societal need for data to be used. I think that it needs to be within the context of good data governance at national level and at international level, so that people understand when and how and where their data will be used. People have the right to give consent and to withdraw consent. And I think that's really the foundations on which the notion of using data for pandemics need to be built. What we've seen in developed but also developing countries is that there are significant challenges with data governance. Data are in silos, data are not linked, they're not interoperable, but there aren't always good national agreed rules of the game about how data are governed and who's responsible for data governance. And I think that if we start with developing a fair and transparent and clear set of rules of the game of how data should be used moving forward, I do think that some of what you've described can be achieved. Over.
Thank you very much. And now to Ambassador Anthony. What is the situation in New Zealand? Is there a rule or a procedure that will allow to use data in a different way than what is considered to be privacy preserving, or you are not willing to compromise the personal privacy concern?
Well, thank you. There is always a way that you can share data in a way which can preserve privacy, I think. I mean, there are solutions to this. I think there are technical solutions. There are systems and tools that can be set up to anonymize and protect data. There are also policy and regulatory safeguards that can be put in place. In New Zealand, I mean, I should acknowledge at this point, actually, the fundamental role of the European Union as a norm setter in this area. So obviously the really significant development in the area of data protection, or one of the most significant ones, was the GDPR, which was adopted a couple of years ago, and that really has taken us forward in quite a significant way globally in terms of the protection of personal data. And in New Zealand, our standard is effectively GDPR, because for any government agency, any individual, any private company that wants to do business or be active in the European Union needs to be sure that it is meeting the standards of the GDPR, or it could be liable for all sorts of consequences. I mean, our framework is very much modelled and very much consistent with that of the European Union. And in fact, I think we're one of the only countries in the world, I think, that has a fully functioning data equivalency agreement in place with the European Union, because our systems are just so similar. So I think those systems are there. They are relatively robust if they're followed. But I think, as has been said, I think the governance overseeing that to make sure that those standards are enforced is pretty critical. But I think the even bigger issue is, even if you have those protections, even if you're able to enforce those protections, and you have robust technical solutions that can actually anonymize personal data, the final step in all of this is public confidence. And getting it right doesn't mean that people will believe that you've got it right. Protecting data is a critical step, but the next step is making sure that people have faith in the integrity of your systems. And I think throughout this pandemic, we've found time and time again that, for instance, some of the contact tracing tools that we've had available to us, some of these were ingeniously designed to make sure that no one's privacy could be violated. Some of them didn't even, capture or store personal data. It was really, they were all about sort of contact between devices rather than actually even saying where you were when you were being traced. But it didn't stop people being afraid of downloading those devices, because they simply didn't believe that their privacy was maintained. And that is a much harder issue. Personally, I believe that the technical issues and the regulatory issues can be solved, certainly in countries like Italy and in the European Union and in New Zealand. But the harder part is getting people to believe that, because there will always be part of the population that simply won't believe what you're telling them, that the assurances you give them. And that's really, I think, where the final yard of having effective data sharing is that part, and it's the hardest in my view.
Thank you very much. Now, Emanuele, your turn.
Well, I think what has been said is really important. I think the public trust is a key element for data security and showing actually how data can be used. I think we have the instrument and the tools to be able to protect data. Speaking, for example, the example I provided, here in the UK, we use trust research environment that usually protected, safe haven that you can actually use and link data, hospital data, and health-related data. And as was mentioned before, I think there are as well statistical tools that you can use to really mask the data and make sure the data are protected. So I think we have all the tools there. I think it's really about making sure that the public is aware of those, that there's a public trust the use of data. And of course, it's very challenging, because every time that the data used in a wrong way, then the trust decrease. I think there are several examples, referring back to UK as well, in which access to, for example, primary care records being questioned, and whether or not there's and that sort of make a really difficult use of data because the public wasn't trusting use of data. And so I think every time is that you sit back and then you need to rebuild that trust, and it's very challenging. So I think as a community that's coming from different aspects, from different from people using the data, for people regulating the data, there need to be really sort of a much stronger movement in terms of how data can be used in a safe way, and so that demonstrating that, so that people can actually trust, and so that in some way that good results can be produced. I think this in some way I've been an epidemiologist and a clinician first, and then an epidemiologist. I think always been keen to use data, and always been quite challenging to explain how data can benefit the public many of the data, many of the research that has been done, for example, usually the lag between the research and the public health implementation is very long. And so people forget about how those implementation actually derive from use of data. And here I think that we have a very big opportunity. Pandemic, many negative aspects, but I think some of the good aspects being how can you actually have a very short time frame between use of data and actually implementation of practice that can actually affect life and public health policy. So I think we should really build on this and really build on the trust of people really to use data, not only for pandemic, but as well for many other health-related issues.
Thank you very much. So I guess that we have concluded our round. So it's up to me to summarize the discussion. So we had a wide panoramic of what the use of data for health is all about. And I think that we have seen different positions, but very complementary and along the same lines. In the end, we all agree that one of the pillars of using data for everything, not only for health, is the quality of data and is how we can access data without violating the trust of people that get transferred into the GDPR. Actually, in the United States, we also use GDPR. So that's one great European success. GDPR is used worldwide. Everybody is using it. Sometimes it's misusing it in the sense that people go over and above what GDPR is asking for, making the life of everybody miserable for people like us who want to use data, but such is life. The last considerations that we just touch upon, but to build trust is not only important to guarantee that the data by the legitimate user of the data is used according to principle, but also to defend the data. And here we go into the security issue, which is a real mega issue right now. So in the United States, every day we have a major incident in the security domain, ransomware, you name it, right? And in particular for hospitals, you can imagine how bad it could be if someone comes in. And we had that situation, I think, Emanuele, in UK, there was a penetration into a London hospital and was pretty much of a disaster, right? So be aware that security is a mega big issue in addition to privacy. So thank you very much for your attention, and thank you very much the panelists for being so gracious, and also the ones who are in remote to endure the difficulties of the connection. But in the end, I think that everybody was able to participate. Okay, thank you very much all.